USMLE Cardiac Emryology. So we have in question number one, we have a 5-year-old boy is brought to the office by his parents for evaluation of cyanosis with minimal exertion. The boy has had occasional episodes of turning blue that first began during infancy and are now occurring more frequently. During the episodes, the boy assumes a squatting position as it makes him feel better. Okay, the family recently immigrated to the US. The boy has never had a medical checkup prior to this visit. Physical examination reveals a prominent right ventricular impulse and a harsh systolic murmur. Which of the following embryological events is most likely mechanism that caused this patient condition? Option A, anomalous pulmonary venous return. Option B, aortic arch constriction. Option C, deviation of the infundibular septum. Option D, endocardial cushion defect. Option E, linear development of the aorticopulmonary septum. Pause it and give the answer. So the correct answer for this question is option C. Let us see to the explanation. This patient is presenting with the tetralogy of Philid. How will be the clinical presentation? Like presenting with cyanotic spells that improve with squatting, right? Prominent right ventricular impulse with that systolic type murmur. This is important. Is consistent with tetralogy of Philid, right? And abnormal neural crystal migration leads to anterior and cephal deviation of the infundibular septum during embryologic development. This is the mechanism which is causing this tetralogy of Philid. That would result in malaligned VSD. This is important, and with that overriding aorta. We will talk about that. Tetralogy of Philid is characterized by four distinct anatomic abnormalities. These are these things. The first one is VSD, right? And with that there is overriding aorta, right? And with that there is right ventricular outflow tract obstruction. These two things are the important regarding this tetralogy of Philid. And what would happen there would be right ventricular hypertrophy. Okay, cyanosis occurs due to the presence of right to left shunt because uh, you know uh, if there is right to left shunt, that would be presented with cyanosis, early cyanosis in patient with severe or worsening right ventricular outflow tract obstruction. The typical harsh systolic ejection murmur over the mid to left upper sternal border is due to the presence of right ventricular outflow tract obstruction. That would be subvalvular pulmonary valve stenosis or supravalvular narrowing in the main pulmonary artery, right? Okay, squatting increases, this thing is important, that would increase peripheral SVR, systemic vascular resistance, that means afterload, right? And decreases the degree of right to left shunting through across the VSD, thereby improving the cyanosis. What they are saying, let's say if this is the heart, right, and there is right to left shunting. Okay, now if one person is squatting, what would happen? The SVR over here would be increased, right? Right. So what would happen? This shunting would be reversed. Let me change my marker. Okay, this would become just like that. So the deoxygenated blood would not go directly into the systemic circulation, right? So that's why the cyanosis would be a little bit resolved. Okay, why not option E? Because in anomalous pulmonary venous return, blood from both the pulmonary, that is oxygenated, and the systemic, that is deoxygenated venous systems flow into the right atrium, right? That would lead to right atrial and ventricular dilation, right? So patients also have right to left atrial shunting with that. What they mean by this is, let's say if this one over here is the oxygenated blood, right? uh, this should be uh, toward the systemic circulation, but instead of that it is going into the right area. Also through the pulmonary artery, this will go to the lungs, right, for oxygenation, right, and this will again enter to the uh, right area. Okay, they are talking about this. Okay, why not option B? Because Aortic arch constriction results in coarctation of aorta, most commonly located just distal to the left subclavian artery. This location is important, okay? Juxtaductal. And the common manifestations include brachial femoral pulse delay. This is important, right? And BP discrepancy between the upper and lower extremities. This thing is important. Okay, why not option D? Failed fusion of the superior and inferior endocardial cushions, right? That, for example, endocardial cushion defect results in defect of AV septum and valves, that is mitral and tricuspid valves. These typically manifest initially as ASD, that is atrial defects, or VSDs with left to right shunting of the blood. Initially it would be left to right shunting, and like ASD and VSD, if they are initially left to right shunting, so they would not present with the cyanosis, right? And whenever uh, there is hypertrophy of the right side, okay, so the shunting would become right toward left side, for example, and that would become like Eisenmenger syndrome, that would cause cyanosis, right? So they are saying over time the increased right sided blood flow to the pulmonary hypertension with reversal of blood flow through the shunt and development of cyanosis, Eisenmenger syndrome. This patient had cyanotic symptoms since birth that wouldn't be expected with isolated endocardial cushion defect. Okay, why not option E? Because the transposition of great arteries results from linear, parallel rather than spiral development of aorticopulmonary septum in utero. So, tautology of Fallot results from the interior encephal deviation of infundibular septum during embryologic development, resulting in malaligned VSD with overriding aorta. As a result, the patient has right ventricular outflow tract obstruction, resulting in systolic type murmur, and squates to increase peripheral SVR afterload and decrease right to left shunting across the VSD. In question number 2, we have a 2-day old boy is being evaluated in the nursery for irritability. He was born to a 22-year-old prima primigravida who received limited prenatal care. Delivery was uncomplicated and Apgar scores were 7 and 8 at 1 and 5 minutes respectively. Temperature is 98 degree Fahrenheit. BP is 70 by 30 mm of mercury. Pulse is 148 per minute and respirations are 68 per minute. On physical examination, the patient is cyanotic and irritable. Auscultation reveals continuous machine-like murmur, okay, appreciated between the scapulae. Serum lactate levels is elevated. Echocardiogram shows the origin of aorta lying interior and to the right of the pulmonary artery. Failure of which of the following processes during embryonic development is most likely responsible for this patient findings on imaging? Option A, fusion. B, obliteration. C, proliferation. D, septation. E, spiraling. Pause it and give the answer. So the correct answer for this question is spiraling. Why? Let us see to the explanation. Normally what happens is there is this septal formation, right? So if there is no septal formation, what would happen? There would be patent truncus arteriosus, and then what happens? There is this spiraling. This would be shifted to the other side. Okay, and if this doesn't happen, then what would happen? There will be transposition of great arteries. That means that oxygenated blood would be formed on one side, and the deoxygenated circuit would be formed on the other side. Let's say this is the deoxygenated blood, and with that on the other side we have the oxygenated circuit, right? So there will be no mixing of blood. So they're saying this newborn's echocardiogram is indicative of transposition of great arteries TGA, a cyanotic congenital heart defect characterized by abnormal origination of the aorta or pulmonary artery. In early gestation, there is a single outflow tract from the rudimentary heart that is subsequently divided into the aorta and with that pulmonary artery by the aorticopulmonary septum, right? This septum normally spirals during outflow tract division to create an anteriorly located pulmonary artery arising from the right ventricle. This is normal phenomena. And posteriorly, there would be aorta arising from the left ventricle, right? TGA occurs due to failing spiraling. This is important of the aorticopulmonary septum, resulting in the interior aorta, right? That originates from the right ventricle, and a posterior pulmonary artery that originates from the left ventricle. And this is an abnormal procedure, right? So what would happen, as I mentioned, there will be parallel pulmonary and systemic circuits that are created, okay? And deoxygenated blood is delivered from the right ventricle to the systemic circulation via the aorta, okay? Neonates with a TGA often have cyanosis, tachypnea, tachycardia immediately after birth. Okay, however, some may have normal examination findings initially due to shunting of oxygenated blood to the systemic circulation via the ductus arteriosus. Right? With cyanosis developing after 24 to 48 hours is the ductus begins to close. Other mixing lesions such as large VSD can also mask the development of clinically apparent cyanosis. In this patient, elevated lactate is caused by high degree of anaerobic metabolism. This is important due to poor oxygen delivery to the tissues. Why not option A and C? Because failed fusion of the septum primum with the endocardial cushions lead to primum type ASD, right? Various failed proliferation of the septum secundum that would lead to secundum type ASD. And in ASD wouldn't cause neonatal cyanosis because that is providing left to right shunting. Okay. Then why not option B? Because failed obliteration of the ductus arteriosus results in PDA, that is parent ductus arteriosus, which by itself wouldn't explain neonatal cyanosis, right? PDA is PDA in patient with TGA tends to delay the development of cyanosis, right? Why not option D? Because failed conotruncal septation results in persistent truncus arteriosus, right? Although affected patients typically develop neonatal cyanosis, yeah, right? But in echocardiogram would reveal a single arterial trunk, right? This patient distinct aorta and pulmonary artery indicate conotruncal septation has occurred, okay? So transposition of great arteries, a cyanotic congenital heart condition resulting from failed spiraling of the aorticopulmonary septum during embryonic development. The aorta aberrantly originates from the right ventricle, so this is abnormality, right? Lies interior to the pulmonary artery and delivers deoxygenated blood to the systemic circulation. Okay, in question number 3 we have a 64-year-old man loses consciousness near the entrance of emergency room. A physician rushes to the patient and palpates a strong pulse along the inner side of the left sternocleidomastoid muscle. The vessel palpated by the doctor is the derivative of which of the following aortic arches? Option A first, B second, C third, D fourth, E sixth. Pause it and give the answer. So the correct answer for this question is option C, right? Let us see to the explanation. This question is really important because it's asked many times, okay? So if we see to the arches and associated cranial nerves, pharyngeal arch, pharyngeal and aortic arch, okay? Without cranial nerve and then key aortic arch derivatives. All these are important. The first pharyngeal and aortic arch, that would the nerve that is associated with that is cranial nerve 5, then with second cranial nerve 7, a gap of 1, okay? Then third, that is cranial nerve 9, that is glossopharyngeal. Then fourth, there is superior, right? Fourth with superior. Then fifth one is obliterated. The sixth one is recurrent, right? Both are the fourth one and sixth one. They are laryngeal branch of vagus nerve, laryngeal branch of vagus nerve. But the fourth one is superior and the sixth one is recurrent. So the one is associated with the derivative of that is maxillary artery, right? Let me change my marker. Okay, one is associated with maxillary artery, second is associated with stapedial artery, and that would finally regresses. Okay, the third one that is associated with common carotid artery, right? At which the doctor which the physician has recently, in this case, has palpated. Okay, so proximal internal carotid artery also with that. Okay, then if we go to the fourth, that would give rise to true aortic arch, right? And with that, subclavian artery. The fifth one has been obliterated. In the sixth one, this one they have also given an MCQ on this. Sixth aortic arch, that would give rise to ductus arteriosus, and also it can also give rise to pulmonary aortis. So during the embryonic development, head, neck, and upper thorax region develop from a set of arches known as pharyngeal arches, right? Each arch is associated with cranial nerve and aortic arch derivative. The vessel palpated in this patient is common carotid artery, which along with proximal portion of the internal carotid artery is derived from third aortic arch, third pharyngeal arch. Okay, the third pharyngeal arch also gave rise to glossopharyngeal nerve, that is cranial nerve 9, parts of the hyoid bone with that, and stylopharyngeus muscle. One option A, the first pharyngeal arch that is associated with trigeminal nerve, cranial nerve 5. This pharyngeal arch gave rise to tensor tympani, right? With that, muscles of mastications, maxilla, and inner ear bone, that is incus malleus. Okay, the associated first arch, aortic arch, regresses almost completely, although it does give rise to the portion of maxillary aortic, right? Okay. One option B, the second pharyngeal arch associated with facial nerve, cranial nerve 7. Okay, facial nerve. This pharyngeal arch gives rise to muscles of facial expression, right, as well as some ear and hyoid structures. Okay, the stapedial artery. This is important. Stapedial artery is derivative of associated second aortic arch, but this vessel typically regresses. Why not option D? Because the fourth pharyngeal arch that is associated with superior, this is important, superior laryngeal branch of vagus nerve. This pharyngeal arch gives rise to many of the muscles of the pharynx, right? And with that, soft palate as well as few laryngeal muscles. Associated fourth aortic arch gives rise to part of true aortic arch, right? With that, subclavian arteries, important. The sixth pharyngeal arch is associated with recurrent, this is important, laryngeal branch of cranial nerve 10. This pharyngeal arch gave rise to most of the muscles of the larynx. Associated aortic arch gave rise to pulmonary arteries and ductus arteriosus. This thing is important, right? Okay. Then, okay, the educational objective is that the common carotid artery and the proximal portion of the internal carotid artery derived from the third aortic arch, right? The third aortic arch is associated with third pharyngeal arch, which gives rise to glossopharyngeal nerve, that is cranial nerve 9, and with that parts of hyoid bone, and with that stylopharyngeus muscle. Okay, good. So in question number 4, we have a 37-year-old woman is brought to the emergency department after developing sudden onset right arm weakness and difficulty speaking. She has no significant medical history but takes oral medication, oral contraceptives. Okay. Um, Examination shows decreased right upper extremity strength and expressive aphasia. Cardiac auscultation is normal. MRI of the brain reveals acute infarction in the left frontal lobe. Further evaluation to determine an etiology is performed during echocardiogram. Agitated normal saline is injected into peripheral vein and bubbles are seen passing into the left side of the heart. Which of the following is most likely cause of the observed finding in this patient? Option A, aplasia of the atrial septum secundum. Option B, failure of aortic pulmonary septum to develop. Option C, incomplete closure of the interventricular foramen. Option D, incomplete fusion of the atrial septum primum and secundum. Option E, persistent channel between aorta and pulmonary artery. Pause it and give the answer. Okay. So the correct answer for this question is option D. Okay. Why option D? Let us into the explanation. Whenever there is aerial separation, this membrane over here is the septum primum, and over here this pore is the ostium primum, right? And these are the endocardial cushions, right? And if we go down, this one over here, which will form on the right side of the septum primum, that is called septum secundum, right? And the ostium secundum, they are formed inside the septum primum, right? And the foramen ovale, that is formed inside the septum secundum, right? So this young patient had a cryptogenic stroke, which is evaluated with echocardiography with bubble study to identify right to left intracardiac shunts, right? This study is performed by injecting agitated normal saline IV and observing for microbubbles in the left heart. Okay, shunt detection is improved by having the patient release a sustained Valsalva maneuver, which increases right atrial pressure. Cryptogenic stroke is frequently associated with ASD, that is, with that atrial septal abnormalities such as parent foramen ovale and ASD, right? Atrial septal defect. Okay. And during fetal development, the foramen ovale shunts oxygenated fetal blood across from the right to the left atrium, right? After delivery, umbilical cord clamping, right? If we clamp that, okay, and decreased pulmonary vascular resistance, lower right atrial pressure, and raise left atrial pressure. So that would close that, okay? This pushes the septum primum against the septum secundum, okay? Closes the foramen ovale, as I talked about this. Over time, fibrosis would occur and the tissue remodeling fuse the flap closed. Now, the problem is when incomplete fusion occurs in approximately 25% of normal adults, resulting in parent foramen ovale. Parent foramen ovale usually remains functionally closed and asymptomatic after birth. His left atrial pressure is greater than the right atrial pressure. However, conditions that raise right atrial pressure above left atrial pressure, for example, Valsalva release, right, produce a transient right to left shunt across the parent foramen ovale. This is particularly concerning in patients with hypercoagulability, that is, for example, oral contraceptive use, is they are at increased risk for venous thrombosis and paradoxical brain embolism, right? Chronically elevated right heart pressure, for example, in case of Eisenmenger syndrome, is not necessary for paradoxical embolism, right? One option A, because ASD results from aplasia of the septum primum, right, or septum secundum during development. Although ASD may lead to paradoxical embolism, it is much less common than parent foramen ovale and characterized by fixed splitting of S2. This is important. We will talk about this thing. There is fixed splitting of S2 sound in case of ASD. Unrepaired ASDs may lead to heart failure, pulmonary hypertension, or Eisenmenger syndrome, right? Okay. Why not option B? Why not option B? Incomplete development of aorticopulmonary septum results in truncus arteriosus, which causes cyanosis in newborns and requires early surgical repair, right? Why not option C? Incomplete closure of the interventricular foramen results in VST, which causes hollow systolic murmur at the lower left sternal border, right? Large VSDs can cause significant left-to-right shunting, leading to heart failure in infancy. However, VSDs infrequently lead to paradoxical embolism. Okay, one option E, the ductus arteriosus functionally closes within 24 hours after delivery. Persistent patent ductus arteriosus causes a continuous murmur, right? And may eventually result in heart failure, pulmonary hypertension, or Eisenmenger syndrome. So the foramen ovale is a patent in approximately 25% of normal adults, although the foramen ovale usually remains functionally closed. Transient increases of right atrial pressure above the left atrial pressure can produce right to left shunt, okay, that would lead to paradoxical embolism of venous clots into the arterial circulation. In question number 5, we have a 1-hour-old girl is evaluated in the delivery room. The infant was born with term was spontaneous vaginal delivery following an uncomplicated pregnancy. The mother is gravida 2, para 2, and has no significant medical history. Afghan scores were 9 and 9, 8, 1 and 5 minutes respectively. The patient has been skin to skin with her mother and breastfed once without difficulty. Physical examination shows a pink okay Physical examination shows a pink alert infant. Cardiac auscultation reveals normal S1 and S2 with no murmurs, and femoral pulses are normal. Which of the following hemodynamic changes most likely occur during the fetal to neonatal transition at birth? So we have SVR, and in that we have pulmonary vascular resistance. What will happen to that? And with that, left ventricular contribution to systemic blood flow. So in option A, SVR decreases, pulmonary vascular resistance decreases, then left ventricular contribution to systemic blood flow increases. Option B, decreases SVR, increases PVR, and with that increases left ventricular contribution to systemic blood flow. Okay, in option C, increases SVR, pulmonary vascular resistance decreases, left ventricular contribution to systemic blood flow decreases. Option D, SVR would be increased, pulmonary vascular resistance would be decreased. They're asking about, whenever there is neonatal, the fetal has been changed to neonatal, right? Okay, and with that, left ventricular contribution to systemic blood flow increases. Option E, increases and then decreases. So pause it and give the answer. So the correct answer for this question is option D, right? Why option D? Let us see to the explanation. As we know that fetal circulation is characterized by high pulmonary vascular resistance, so that blood shouldn't go to the lungs, right? In utero, the lungs are filled with amniotic fluid, which causes diffuse vasoconstriction of the pulmonary capillary beds, hypoxic vasoconstriction, right? And there is low SVR. Why? Because the fetal's systemic circulation is connected in parallel to low resistance placental vascular bed via the umbilical arteries, which deliver deoxygenated blood to the placenta, an umbilical vein which delivers oxygenated blood to the fetus. So in the fetus, PVR is greater than SVR. The foramen ovale and ductus arteriosus allow blood to be shunted away from the high resistance pulmonary circulation into the low resistance SV systemic circulation, that is left to right shunting is there in fetus, bypassing the lungs. Because the ductus arteriosus is high caliber shunt, the right ventricle contributes approximately 60% of the fetal systemic blood flow, and the left ventricle contributes the remainder. Okay, now what happens at birth? Fetal circulation transitions to neonatal circulation, which is characterized by, so there will be decreased in pulmonary vascular resistance. Why? Because there is pulmonary expansion and there is aeration that would lead to diffuse pulmonary vasodilation, right? And there is increased SVR because the umbilical cord clamping abruptly removes the low resistance placenta from neonatal circulation. Because SVR is now greater than PVR, shunting through the ductus arteriosus reverses to left to right shunting, triggering eventual closure of the ductus. With the cessation of the right to left shunting to the ductus arteriosus at birth, only the left ventricle contributes to systemic blood flow. So before birth, high PVR and low SVR facilitate right to left shunting through the ductus arteriosus, and both ventricles contribute to fetal systemic blood flow. This is important. At birth, decreased pulmonary vascular resistance lead to oxygenation and ventilation of the lungs, and increased SVR, right, due to umbilical cord clamping, reverses shunting to the ductus arteriosus, that is left to right shunting, and only the left ventricle contributes to the systemic blood flow, right? In question number 6, we have researchers conduct a study in animal fetus with circulation similar to that of humans. The fetus is delivered close to the term by cesarean delivery prior to placental separation and the initiation of pulmonary respirations. Blood samples are simultaneously collected from several different uh, fetal blood vessels. The blood oxygen saturations measured from each of the samples are 71%, 64%, 62%, 55%, and 43%. The samples with the greatest oxygen saturation was most likely obtained from which of the following blood vessels? So they're asking about more oxygenated blood vessel, right? Option A, descending aorta. Option B, ductus arteriosus. Option C, inferior vena cava. Option D, pulmonary trunk. Option E, superior vena cava. Option F, umbilical artery. So what do you think, which one would have the more oxygenation, right? So pause it and give the answer. So the correct answer for this question is option C, right? This is option C. Why option C? Let us see the explanation. Because if we look to the fetal circulation, right, the umbilical veins are carrying oxygenated blood to the fetus from placenta. So some of the blood will be going through the into the portal vein, right? But what would happen? Some of the blood is most of the blood is shunted to the ductus venosus, right, uh, through the and that would pass into the inferior vena cava, that would bypassing the liver, right? So is they have not mentioned umbilical vein, which would have most of the oxygenated blood, but with that is they have not mentioned. So ductus venosus, his greatest oxygenated blood, that would then passes into the inferior vena cava, right? So as they have mentioned inferior vena cava, so the correct answer for this question is inferior vena cava, right? While the other things have little bit less oxygen, so would not match that much. Okay, so fetal circulation differs considerably from adult circulation in that oxygen is supplied to the fetus by the mother's placenta. No gas exchange occurs in the fetal lungs. This is important. And the majority of the blood is directed away from the lungs, while right to left shunting, for example, through foramen ovale and ductus arteriosus. Oxygenated blood from the placenta is delivered to the fetus via the umbilical vein, as I mentioned this thing. Upon entering the fetal abdomen, a portion of this oxygen-rich blood is directed to the portal vein to supply the liver, while majority of this is shunted to the ductus arteriosus. Majority is shunted, right? This is important. Via to the inferior vena cava via ductus venosus. Okay. In the inferior vena cava, oxygenated rich blood from the ductus venosus runs alongside a stream of deoxygenated blood returning from the lower body. Okay, is blood from the inferior vena cava enters the right atrium. A preferential streaming effect allows the majority of the oxygenated blood to pass directly to the foramen ovale into the left atrium, right? This is important. The oxygen rich blood delivered to the left atrium proceeds to the left ventricle and out of the aorta, where it is supplied to the brain, myocardium, via the coronary arteries and upper extremities. Meanwhile, deoxygenated blood from the inferior vena cava and superior vena cava fills the right atrium, proceeds to the right ventricle. High pulmonary vascular resistance causes most of the blood ejected into the pulmonary trunk to be shunted away from the lungs, with 90% of the deoxygenated blood uh, being shunted through the ductus arteriosus into the aorta, right? This deoxygenated blood mixes with the oxygen rich blood in the aorta, sending moderately oxygenated blood down the descending aorta, supplies the intestines, kidneys, and the lower body. This is important. This is moderately oxygenated, which will be going to the intestines, kidneys, and lower body. While the full concentrated, highly concentrated with oxygen, was shunted through the foramen valve, and that was reached to the brain, myocardium, and upper extremities, right? Why not option? Why not other option? Why not option A? Oxygen saturation in the descending aorta is significantly lower than in the ductus venosus, because the oxygenated blood in the descending aorta is mixed with the deoxygenated blood from both the lower and upper body. This is important. The superior vena cava carries deoxygenated blood returning from the brain and with that upper extremities. Why not option F? Umbilical arteries branch off the internal iliac arteries to return moderately oxygenated blood to the placenta when carbon dioxide and other wastes are unloaded and oxygen is again collected. So the most highly oxygenated blood in the fetus is carried by the umbilical vein. This is important, which empties directly into the inferior vena cava via the ductus venosus. So over here we finished the cardiac embryology portion from UWorld.